DMC Safety for Life. Safety for Life Training Module 1. Why Errors Occur. Safety of patients and employees has always been a priority at the DMC and a core value. DMC has begun a journey to create a culture of safety, and each one of us has a role in making that happen. This is the first of 3 sessions that will be offered over the coming year. Today, we will give you an overview of a high-reliability organization, why errors occur, and what you can do to identify unsafe behaviors and prevent errors. Over the course of the next couple of months, we are going to be providing you the tools and teaching you techniques to assist you in helping us make our hospital an even safer place. This is about making safety a priority. Patient and employee safety starts with each and every one of us.
My daughter Josie died a year and a half ago at Johns Hopkins due to medical errors. Last week, I had the opportunity to speak at Grand Rounds to the doctors, nurses, and leadership of the hospital. I spoke about what happened to Josie and about the Josie King patient safety program that is being launched. Reliving our tragedy was a painful and difficult thing for me to do. When Peter asked me 2 days later if I would be interested in going to Boston to speak at this conference, I quite honestly was not sure I had the strength to do it again so soon. After thinking about it, I realized I had to be here. Not only do I represent Josie, but I also represent all of the other children, the mothers, the fathers, the sisters, the brothers, the 98,000 people who die every year in this country from medical errors. I'm here for them, for their families, and for any future potential victims. I would like to share my story with you. I do this with the hope that what I'm about to tell you will make a difference in how you care for your patients and how strongly committed you and your hospital are to patient safety. Josie was 18 months old. She had brown eyes and light brown hair. She loved to dance and had just learned to bounce on the trampoline with her older siblings, Jack, Relly, and Eva. She had just learned to say, "I love you." In January of 2001, Josie was admitted to Johns Hopkins after suffering 1st and 2nd degree burns from climbing into a hot bath. She healed well and within weeks was scheduled for release. 2 days before she was to return home, she died of severe dehydration and misused narcotics. I would like to take you through the events that resulted in this needless tragedy. Josie spent 10 days in the PICU. I was by her side every day and night. I paid attention to every minute detail of the doctors' and nurses' care, and I was quick to ask questions. I bonded with them and was in constant awe of the medical attention she received. Every time Josie moved or fussed, someone would be quick to push her pain button. I tried rubbing her head and found that often this would settle her. Much to our relief, Josie was experiencing a quick recovery. Her burns were healing beautifully. She was sent down to the intermediate care floor with expectations of being sent home in a few days. Her 3 older siblings prepared for her welcome home celebration. We were told that no one had ever been sent back up to the PICU. The following week, her central line had been taken out. I began noticing that every time she saw a drink, she would scream for it, and I thought this was strange. I was told not to let her drink. While a nurse and I gave her a bath, she sucked furiously on a washcloth. As I put her to bed, I noticed that her eyes were rolling back in her head. Although I asked the nurse to call the doctor, she reassured me that oftentimes children did this and her vitals were fine. I told her Josie had never done this, and perhaps another nurse could look at her. After yet another reassurance from another nurse that everything was fine, I was told that it was okay for me to sleep at home. I called to check in 2 times during the night and returned to the hospital at 5:30 in the morning. I took one look at Josie and demanded that a doctor come at once. She was not fine. Josie's medical team arrived and administered 2 shots of Narcan. I asked if she could have something to drink. The request was approved, and Josie gulped down nearly a liter of juice. Verbal orders were issued for there to be no narcotics given. As I sat with Josie, I noticed that the nurse on morning duty was acting very strangely. She seemed nervous, overly demonstrative, and in a hurry. Uneasy, I asked the other nurses about her, and they said she had been a nurse for a long time. Still worried, I expressed my concern to one of the doctors, and he agreed that she was acting a bit odd. Meanwhile, Josie started perking up. She was more alert and had kept all the liquids down. I was still scared and asked her doctors to please stay close by. At 1 o'clock, the nurse walked over with a syringe of methadone. Alarmed, I told her there had been an order for no narcotics. She said the orders had been changed and administered the drug. Josie's heart stopped as I was rubbing her feet. Her eyes were fixed, and I screamed for help. I stood helpless as a crowd of doctors and nurses came running into her room. I was ushered into a small room with a chaplain. The next time I saw Josie, she had been moved back up to the PICU. Doctors and nurses were standing around her bed. No one seemed to want to look at me. She was hooked up to many machines, and her leg was black and blue. I looked into their faces and said to them, "You did this to her, now you must fix her." I was told to pray. 2 days later, Jack, Relly, and Eva were brought to the hospital to kiss their beloved Josie goodbye. Josie was taken off of life support. She died in our arms on a snowy night in what's considered to be one of the best hospitals in the world. Our lives were shattered and changed forever. Josie died from severe dehydration and misused narcotics. Careless human errors. On top of our overwhelming sorrow and intense grief, we were consumed by anger. They say anger can do one of two things to you. It can cause you to rot away, or it can propel you forward. There were days when all I wanted was to destroy the hospital and then put an end to my own pain. My 3 remaining children were my only reason for getting out of bed and functioning. One day, I will tell them how they saved my life. Tony and I decided that we had to let the anger move us forward. We would do something good that would help prevent this from ever happening to a child again. It seemed the best place to start was with Johns Hopkins. Over the past year and a half, we have worked with the hospital to create the Josie King Patient Safety Program. Together, we launched the program last week. Josie's death was not the fault of one doctor or one nurse or one misplaced decimal point. It was the result of a total breakdown in the system. It was the result of a complete lack of communication between the different teams. It was the result of doctors and nurses not listening to a concerned parent. It was the result of a combination of many errors, all of which were avoidable. What if the nurse had called the doctor when Josie's eyes were rolling back in her head? What if she could have had a drink or had been hooked up to an IV? What if the residents had paid attention and seen that her weight had dropped over 15% in 24 hours? What if the nurse had not given her the methadone? What if someone had taken my concerns seriously? What if a patient safety program had been in place? I believe that if any one of these things had occurred, the outcome could have been different and Josie would be here today. 98,000 people die every year because of medical errors. Hospital errors are among the top 4 leading causes of death in the country. This problem is unlike cancer, AIDS, or other diseases where we must wait for a scientific breakthrough in order to save lives. Hospitals are a man-made epidemic. Nurses and doctors make mistakes and lives are being lost. These human errors need a human solution. You are the only ones that can solve this problem, not lawyers, not insurance companies, and not people like me. Much has to be done to accomplish this. We can start by first admitting to ourselves that we are fallible. The medical community must be open to the possibility that shortcomings do exist. and you must be prepared to make the necessary changes. Please take the time to listen to a parent when they are concerned. Please learn to trust a parent's instincts. Please communicate with each other, nurses to doctors, one team to another team. Please listen to the child. Is she crying because she's in pain, or is there some other reason? Please look at the child. Not all the answers are on your clipboards or computers. Thank you for listening to me today. For the past year and a half, I have known I would one day find the strength to share this story with those who can make a difference. My precious memories and everlasting love for Josie give me this strength, and I will not rest until we make something good come from her senseless death. I will not rest until hospitals become safer places. I am not asking for your pity. I'm asking for your help. I do not know the answers. I only know that there is a problem that must be solved. Some of the best and brightest doctors and nurses in the country are in this room, and I know that together, if we are all committed and work hard, we can control hospital errors, and we can save the lives of other potential victims, other helpless children. Thank you.
It is important to include patients and families in care. Listen to patients and families. They are an invaluable source of information to us, but we must be willing to listen and respond to their questions and concerns. Both doctors agreed with me and issued a verbal order that no more narcotics be given. At 1 p.m., the nurse walked in with a syringe of methadone. I asked her what she was doing and said that the doctor had given orders for Josie not to receive any more methadone. "Don't give it to her," I said as she neared Josie's bed. "The orders have been changed," she responded. The nurse squirted the drug in Josie's mouth. When I looked at Josie, I stopped dead in my tracks. Her eyes had rolled back in her head. "Josie? Josie!" I shook her. She was not responding. Mrs. King, Josie, should not have died. And yes, you are right. She probably would be alive if any of us had listened. Sorrel King, Josie's story. These examples illustrate that safety is everyone's job, not just those persons who come in contact with the patient. A hospital is first and foremost a patient care enterprise. Every job is important to patient safety. Work performed by all individuals up and downstream is essential to cultivate high reliability organizations. In 2005, Duke Health System announced that maintenance staff drained hydraulic oil from elevators into detergent containers during their normal maintenance processes. Subsequently, the hydraulic oil was utilized during the operating room sterilization processes. The surgical instruments exposed to the hydraulic oil were used in multiple surgical cases before the error was discovered. Linda McDougall underwent a double mastectomy only to be told after surgery that she never had cancer. The lab had mixed up her pathology results with those of another patient. Safety perceptions. Someone you care about has just been admitted to the hospital. What concerns you the most when it comes to keeping them safe? Think about it this way. I would be worried about blank because blank. Think about hospital safety in terms of yourself or a loved one. What concerns would you have? Risks to hospitalized patients. Healthcare is considered a high-risk industry. When someone is admitted into a U.S. hospital today, there is a 30% chance that that person will experience a medical error. For those experiencing an error, there is a roughly 4% chance that that error will result in injury, and a 3 in every 1,000 chance that that injury will result in death. Risks of death comparison. So how does healthcare compare to other high-risk industries? Nuclear industry. Chance of dying from radiation exposure while living next door to a nuclear energy plant is 1 in 100 million per year. Domestic commercial airline. Chance of dying during a flight on a U.S. carrier within the country is 1 in 10 million per flight. The risk of death in healthcare is much greater. So what is a high reliability organization? High reliability organizations, or HROs, operate under very trying conditions all the time and yet manage to have fewer than their fair share of accidents. Risk is a function of probability and consequence. By decreasing the probability of an accident, HROs recast a high-risk enterprise as merely a high-consequence enterprise. HROs operate as to make systems ultra-safe. Why are we here? What is the risk of injury or death from a healthcare error at the DMC? On average, every 15 days, a DMC patient is significantly harmed due to preventable errors. On average, every 78 days, a DMC patient dies due to preventable errors. The DMC has adopted safety as our #1 value. From the patient's perspective, this is what is important. Don't hurt me, heal me, be nice to me, and include me. In this order, safety is the patient's priority too. Sometimes human errors and weaknesses in our systems and processes do come together to reach our patients and result in a serious safety event. The blue bars represent the number of cases causing patient harm per month. The red line represents the hospital rate of cases causing patient harm per month on a rolling 12-month average. To get to 0 events per month, we have to go a full year without a serious safety event. As you can see, our SSER trending is up, likely due to recent increased awareness. Hopefully, as we introduce these error prevention behaviors, we will see a downward trend. Event detection. Are we having more serious safety events, or are we doing a better job identifying and reporting events? Principles of high reliability organizations. Preoccupation with failure. Regarding small, inconsequential errors as a symptom that something's wrong. Commitment to resilience. Developing capabilities to detect, contain, and bounce back from events that do occur. The anatomy of a safety event. There are 3 event categories: serious safety events, precursor safety events, and near-miss safety events. The event may or may not reach the patient. The event may or may not cause harm. There may or may not be any deviation from generally accepted practices. This is a safety event classification tool. This methodology is being used by all Vanguard hospitals. A near-miss safety event does not reach the patient. Error is caught by a detection barrier or by chance. An example of a near-miss safety event, also known as a good catch, would be if the wrong patient was taken to CT scan but the tech recognized that it was not the correct patient. Precursor safety events reaches the patient, results in minimal harm or no detectable harm. An example of a precursor safety event would be if the wrong dose of medication was given to the patient but the patient suffered no harm. Serious safety events reaches the patient, result in moderate to severe harm or death. An example of a serious safety event would be wrong site surgery. The anatomy of an event. This is called the Swiss cheese model, representing how an error passes through many layers before it reaches the patient. The slices represent barriers created to prevent harm. There are multiple barriers such as technology, processes, and people designed to stop active errors. The holes in the slices represent gaps in the barriers, like active errors by individuals resulting in initiating actions, and latent weaknesses in the barriers. When all the holes line up, the error is allowed to go all the way through and reach the patient, which is the event of harm. We need to prevent the errors and detect and correct the system weaknesses. Research has shown that individuals are involved in 90% of all adverse events and that system factors are present in 70 to 85% of events. On average, 8 inappropriate acts occur with each sentinel event. Eliminating 1 will prevent the adverse event. Barriers to prevent event fail, wrong side surgery. This is an example of how multiple barriers fail, which results in an adverse event reaching the patient. A patient presents for knee surgery. While the surgeon marks the correct knee, he does not follow hospital marking policy. Then, the RN sets up the equipment on the wrong side of the OR table. The surgical assistant uses the equipment as the guide to determine which knee to prep. Following that, the surgical team doesn't do a complete timeout. As a result of these barriers, a trocar was placed in the wrong knee. 3 ways humans perform. Human beings perform in 3 different ways: skill-based performance or autopilot mode, rule-based performance, if-then response mode, and knowledge-based mode, the figuring it out mode. These performances can result in 3 different types of error. Skill-based errors are a slip or lapse, like locking your keys in your car. Rule-based errors occur when failing to follow policy and procedures. Knowledge-based errors occur when an individual is not familiar with a procedure, equipment, etc. Skill-based errors. Skill-based errors occur when what we are doing is so routine and familiar that we don't even have to think about the task while we are doing it. A slip. Without intending to, we do the wrong thing, like when we put the box of cereal in the refrigerator instead of the cupboard. Or a lapse, when we fail to do what we meant to do. How many times do you go down into the basement to get something and come back up without it? An error prevention strategy to help prevent skill-based errors is to stop and think before acting. In healthcare, skill-based errors comprise about 25% of all errors. Rule-based errors. Rule-based errors occur when we choose how to respond to a situation using a rule we were taught or told or learned through experience. There are 3 types of rule-based errors. Frequently, these rule-based errors are shortcuts. They are: used the wrong rule, we were taught or learned the wrong response for the situation; misapplied a rule, we knew the right response but picked another response instead; choose not to follow the rule, usually because we thought not following the rule was the better option at the time. Each rule-based error has a prevention strategy. When you use the wrong rule, you can gain education about the correct rule. When you misapply a rule, you can think a second time, validate and verify. When you choose not to follow a rule, you might need a reduced burden, increased risk awareness, or improved coaching. In healthcare, rule-based errors comprise on average 60% of all errors. Knowledge-based errors. Knowledge-based errors occur when we're problem-solving in a new, unfamiliar situation. We don't have a skill for the situation, we don't know the rules, or no rule exists. So we come up with the answer by using what we do know, the fundamentals, taking a guess, or figuring it out by trial and error. The result is that we come up with the wrong answer, or make a mistake. To prevent knowledge-based errors, it's important to find someone like an expert who knows the right answer. In healthcare, knowledge-based errors comprise on average 15% of all errors. Safety. It doesn't just happen. Not all situations are created equal. Some situations are inherently more risky than others. Which is riskier? Walking on a hardwood staircase or a carpeted staircase in socks? Driving in the rain or snow, or driving under dry conditions? Administering blood, or administering Maalox or Mylanta? When we practice our safety behaviors in high-risk situations, there's less chance for an event of harm to occur. 3 actions we can take as individuals to make safety happen are: number 1, recognize high-risk situations and improve processes to reduce risk; number 2, practice safety behaviors to prevent human error, know high-risk behaviors in high-risk situations; and 3, stop the line when unsure and find an expert. If faced with a choice. Do you ever feel that you have to compromise safety to respond to another priority? But if faced with a choice, always choose safety first. What would you do? You are in a patient's room with a patient sitter. The sitter attempts to stop the patient who is unlatching her Foley bag from the frame of the bed to walk to the bathroom. The sitter gently takes the Foley bag in her hand to assist the patient in walking to the bathroom. The patient refuses her assistance, stating, "I can do this myself." The sitter places her hand on the arm of the patient, looks her in the eye and states, "I know that you feel you are capable. However, hospitals across the country have noted patients who are independent before surgery become at risk for falling post-surgery. We have witnessed facial fractures, head injuries with concussion, and hip fractures. It is my job to protect you from falling. I can walk with you, place you in a wheelchair, or bring you the bedpan. Of these 3 choices, how would you like to proceed?" The patient begrudgingly allows you to walk her to the bathroom. As healthcare providers, we have many competing priorities, but our number 1 priority must be safety for our patients, safety for ourselves, and safety for life. The loudest message wins in the millions of moment-to-moment decisions made each day at the DMC.